So welcome everyone and to the lightning talk room on provider behavior change and service communication. My name is Angela Acosta. I'm a senior program officer with the Johns Hopkins Center for Communication Programs and a member of the working group steering committee. Next slide. As before, please note that slides are in English, French, and Portuguese. You can find the link to those presentations here on this slide, www.bit.ly/2002VF. Please go to the folder called Room 3 and find the slides that are specific to your language. Next slide. Today's presentations focus on provider behavior change and service communication. Service communication refers to the use of social and behavior change processes and techniques to motivate health service-related behaviors. Service communication initiatives seek to get more clients to health facilities, improve client-provider interactions, and increase the adoption and maintenance of healthy behavior. Provider behavior change refers to initiatives intended to positively influence provider behavior. These can include initiatives intended to encourage adherence to case management and malaria pregnancy guidelines. Provider behavior is influenced by many factors, including values, social norms, supervision, skills, knowledge, and the structural context. And provider behavior change initiatives can utilize a behavioral lens to understand and address those factors. Both service communication and provider behavior change are essential for improving service delivery and encouraging clients to seek services and maintain healthy malaria behaviors. Each of our presentations will be 5 minutes, followed by a brief 3-minute question and answer session. During the presentations, please type your questions in the chat and I will ask them during the Q&A session. Our agenda is full today and I have a timer here that I will stick to closely. Presenters, I will warn you once you have reached your allotted 5 minutes. If you go over your 5 minutes, I will have to shorten the Q&A session. Please stick to time. To our attendees, thank you for joining us today. Please remain muted. If you have any questions for the presenters, again, please put them in the chat and I'll ask them during the Q&A session. With that, let's get started. Over to you, Jessica.
Thank you so much. You can go directly to the next slide, please. Today I'll be presenting on a segmentation that was conducted by Canberra Collective, who is a partner of the Breakthrough Action Program. My colleague Abdel Agadazi presented yesterday, if any of you were able to attend, on a similar type of project where we did a segmentation of women for ANC visits. This one in particular was done amongst providers. We were very fortunate to be able to use secondary data that was already available and collected. For this, we used health facility survey data from both Guinea and Uganda. And similar to the ANC presentation you saw yesterday, we ran different analyses involving latent cluster analyses as well, and found 4 segments of providers, which you see in the middle of the slide, ranging from high performers to low performers, and then with 2 segments in the middle. The outcomes of interest, really the variables we were looking at most closely, were around adherence to service provision guidelines with regards to diagnosis and treatment of malaria. And we also wanted to understand the varying levels of importance of quality of service among providers. So high performers, to say sort of shorthand, ranked the best across in terms of service adherence to service guidelines and also quality of services, whereas low performers, as you can imagine, were the bottom end of the scale. Pragmatics and overconfidence landed somewhere in the middle, but for different reasons. Key differences being pragmatics having trust in malaria tests, however, might still treat a malaria case even if the test was negative for practical reasons, such as belief that living in an endemic area, it's good to treat, it might be preventative, etc. Versus overconfidence have lower trust in malaria tests and might be willing to treat when tests are negative because they believe that they have their clinical guidance is sufficient for them to be able to diagnose themselves. So we conducted the segmentation. We found these 4 segments in the quantitative data. They exist both in Guinea and in Uganda. But because this was secondary data, we weren't able to ask all of the questions we wanted to. So we complemented this with some qualitative focus groups in Guinea, which we conducted over the summer. We had focus groups per segment and tried to better understand some nuances around the segments, and also worked up some recommendations by segment with in-country stakeholders. What you see on the very far right side of the slide are some of the things we found in the qualitative data and the qualitative research. So trust in tests actually really importantly break out into different levels of trust in RDTs versus microscopy. As you can probably assume, and what you've probably seen in literature, trust in microscopy is quite high, and this was true across almost all segments with some slight differences. It was really trust in RDTs that was a distinguishing factor across the segments, was quite consistent with what we saw in the quantitative research, where higher performers and pragmatics tended to trust the RDTs more, and lower performers and overconfidence trusted less. Quality of services was an interesting question, really was a bit more varied. In the quantitative survey, we based this on one question around importance of quality of service, whereas in the qualitative research, we went quite a bit further and understood more around quality of service, whereas some providers thought it was important to gain trust of clients more from a self-serving perspective of really understanding if they've self-medicated or any information that the patient might not be willing to give readily, versus on the other spectrum, really providers that go above and beyond, calling patients to make sure they're adhering to treatment schedules, et cetera. And so the outcomes of this is we workshopped some recommendations within country stakeholders. For example, need for supervision was something that was requested across the board, across providers, and it might be interesting to have higher performers play more of a role in peer-to-peer training and potentially supervision. Potentially leveraging existing tools. Notably, one was mentioned from Nigeria, where there was a tool that would help providers diagnose even when tests were negative and they felt a bit stuck wanting to treat and not knowing what else to be looking for. And that could really be adapted with specific messages by segments, as their rationale for treating when tests are negative was slightly different. And quality of services, I think, across the board could emphasize the importance of quality of care for patients, et cetera. So we've had a workshop in country and have developed recommendations for potential next steps. And I think that's probably about 5 minutes.
Thanks, Jessica. You actually had 20 seconds left, but I appreciate your concluding on time. Okay. This is a good time to enter any questions you may have for Jessica in the chat. Okay, we have here a question. Was trust in RDTs related to ease of access of patients?
I'm not sure I understand ease of access of patients. There was mention of RDT availability. Maybe if the person who asked that question could clarify what you mean by ease of access of patients, just to make sure I answer correctly.
Elizabeth, can you clarify your question? What kind of access? Was it access to the patient? Oh, that you won't be able to follow up. If a patient perhaps was negative for malaria, and they're ill, and there's a concern that if the patient returns home, you won't be able to follow up with them. Okay. Did that come out in your qualitative or quantitative analysis?
Okay, thanks so much for clarifying. I would have answered something different. There wasn't a specific concern around not being able to reach the patient after. If patients tested negative with an RDT, unfortunately, in most cases, that wasn't sufficient. Even for most of the segments, the high performers were the ones that might refer in that case or look for other diagnoses. But by and large, if microscopy was available, that was then the next step in treatment. So there was some segments, notably the pragmatics, who would treat while they waited for the microscopy test results because they didn't want the malaria to progress from a simple case to a severe case. So we did, in a similar sense, not wanting to sort of lose track of the patient or have time evolve where they're not able to treat, they would go ahead and treat in advance. So I wouldn't say it related to some extent it relates to trust in RDTs in the sense that they didn't quite believe that that RDT test was negative, but sort of this pragmatic sense of wanting to treat while they waited for the quote unquote more reliable test.
Thank you. We have a second question, and I believe that's all we'll have time for at the moment, which is how would you recommend countries identify or programs identify which providers fall into which segment? Seems like this ability to do so would be very important in order to allow us to tailor our messages or tools.
Yeah, absolutely. Well, so two things. I think on the one level, if there's a health facility survey data that's available in the country, the segmentation could be rerun using the same variables. So I think that could provide some sort of overarching view of what the proportions of the segments in a given country. However, alternatively, or in addition, one thing that we developed was a profiling tool. Using the 2 data sets that we used to create segmentation, we've distilled it down into probably about, I think it's 4 or 5 questions. And that's what we used for recruiting providers into the focus group discussions. So using that 4 to 5 question screening tool, a supervisor or someone at the Ministry of Health or an implementing partner could integrate that into a program and segment and figure out which providers belong to which segments.
Thank you.
Yep.
Great. Looks like there's an interest in seeing this profiling tool. Will it be possible to share that, or
Yes.
How might people access that?
Yep, we're just finishing up this phase of the activity now. So I think once we have finalized materials approved, we can share them out.
Thank you. In the interest of time, we're going to move on to our second presentation. Thank you again, Jessica, for a very interesting presentation. Now I'd like to welcome Rukia Nakamate from the Uganda National Malaria Control Program. The floor is yours, Rukia.
Thank you very much. Good morning, good afternoon, everyone. Like I've said, it has been mentioned, I am Rukia Nakamate, and I'm a BCC specialist with the National Malaria Control Program in the Ministry of Health. My abstract is an experience-based observation on the impact of health provider communication during epidemics. And we are looking at, could this be a trigger for behavior change in malaria epidemics? So as a way of background is that malaria remains one of the causes of morbidity and mortality in Uganda, and the entire country is endemic to the disease and about 5% prone to an epidemic. So traditionally, epidemics have occurred in areas of unsustainable transmission or areas with low endemicity. So in June last year, districts across the country in Uganda experienced a malaria epidemic with an increased mortality rate of 30%. There was an increased hospital admission of about 43% and over 80% of outpatients. Definitely, there was also a very big increase in the positivity rates. So due to the increased number of cases, we prioritize health provider communication as a key vehicle for SBC to curb the transmission of the parasite at the community level. This was as a result of an assessment that was done by a campaign that we earlier conducted with the support of USAID and the Ministry of Health, which was the Chase Malaria campaign, which identified health workers as key communicators. So in this, we a total of 300 health workers were mentored on the appreciation of health provider communication. These health workers conducted community outreach programs focusing on health promotion, disease prevention. Each health facility was supported to conduct outreach programs on a weekly basis. So this study explores how health provider communication amidst an upsurge can influence early treatment seeking behaviors among clients and also other key malaria interventions. This study was a mixed study with an intervention and control arm, and it was highly qualitative. This study targeted the most malaria epidemic hit districts of Bugiri and Namutumba, which are found in eastern Uganda. And in each of these districts, household surveys were conducted in 15 households, in 6 villages, and in 5 parishes in 4 sub-counties of each of the districts. Additionally, we conducted exit interviews at facilities, at most of the facilities in these sub-counties. In the control arm, all health workers continued with their standard of care. So baseline data of the HMIS at the time of the epidemic was conducted at the 3rd month. So what are some of the key findings of this survey? We realized that during the interactions, over 80% of the community members confirmed that health providers were the source of information during the epidemic period. We also noticed that there was high exposure of malaria messages in the targeted audiences, majorly in the intervention arm. Health providers also acted as the major source of reliable information in the community. Another finding was results of the intervention residents or in the intervention arm were 8 times likely to seek care within 24 hours on onset of the symptoms. Largely, there was improved follow-up on patients by the health providers because they continued to undertake community outreaches. Individuals with high message exposure had 1.4 higher odds of perceiving malaria as a risk compared to their counterparts in the control arm. And lastly, as one of the findings is that area lines used in the intervention arm improved because area line was one of the interventions that was majorly focused on during the communications. So every client in the intervention arm claimed to have slept under a mosquito net during the time of the review. And what are some of the implications that we saw in this survey? We realized that health providers need mentorship on communication because this is not being done at most of the health facilities. Another implication is that SBC activities should largely engage health providers on the importance of counseling, assuring clients and follow-up of clients to address perceived barriers to malaria. Targeted messages are effective for clear knowledge, attitude, and change during an epidemic situation. This shouldn't be like this shouldn't be done like in a normal or a routine setting. And lastly, the last implication is that the second last implication we have is that there should be more regularity of health promotion desks during epidemics. And finally, during epidemics, other malaria interventions should be reinforced in order to bring down epidemics and cut transmission. Thank you very much. Back to you.
Thank you, Rukia. Now I'd like to open the floor to questions. If you have any questions, please do put them here in the chat. So I see here we have a question from Umu. Is there any training on interpersonal communication, perhaps around epidemics or just in general, currently being done for these health workers? And to add to that, Rukia, how might we strengthen mentorship around health communication for health workers, since that was one of your recommendations?
Thank you very much. How can we strengthen mentorship? What we did is that we designed a mentorship tool for health providers, which we took down to the districts and we engaged the district DHT team. We took them through a training, which was cascaded to the different health facilities. In these mentorships, all cadres, irrespective of whether you're working with malaria or not, but cadres within the service line were mentored. So with this guide, we put down guidelines on which every health worker at whichever level they are conducting were taken through a series of trainings to be able to capture the necessary information that they should be giving out to clients during the epidemic.
Great, thank you, Rukia. We have a question here from Kong. Is there any involvement of, can you speak more about the role or importance of community volunteers in epidemic control?
Thank you very much. I want to say that during the community outreach programs that were being conducted by the health workers were working closely with our community volunteers who are the village health teams. We have 2 village health team members in each village, and they were working with the health workers. The VHTs were able to identify the homes that posted more malaria cases, and they are the ones that led the health workers to these homes. Good enough, we have a program of integrated community case management for malaria, where these VHTs are able to track homes that are posting more malaria cases. So they were working closely with the health providers.
Thank you, Rukia. That was very interesting. We are at the end of our time with Rukia at the moment, and I'd like to move to our third and final presenter in our lightning room, Lottie Mwale. Lottie, can you say hi and introduce yourself?
Hello, I'm around.
Hello, Lottie. Welcome.
Thank you. Am I audible?
Yes, you are very audible.
Yes.
Lottie, you have 5 minutes to present, and there are 3 minutes for questions afterwards. The floor is yours.
Okay.
Welcome.
Okay, so as the title is, I'm talking about the use of effective model for behavior change through information, education, and communication. Our background into this is all about, one of them is we have a group that was formed, and in the group, one of the persons suffered from malaria and took the drug to the last drug of malaria. And fortunately, he was healed, and we started this group. In the community, as you may see from the background, we identified issues that even those who have suffered from it within the group went through. There has been misuse of items being used as ropes, fishing nets, covering of gardens for the chickens not to be picking their vegetables. And also we have found lack of adherence as being common within the communities. Also an emphasis on saying that the drug, most especially this current drug, Coartem, some people do not finish it just because of what they experience. And also, we therefore came up with an idea to be sensitizing the community and so that they can have information on their fingertips. Some of the most important targets that we have identified that have a problem are people like the pregnant women, because either they go to the hospital late to discover they have malaria and pregnancy at the same time. And also we encourage the community to register early so they can be protected against malaria during pregnancy. The method that we used during this time is that we were able, as I have said in the background, that one person was sick and with malaria and had the treatment to the last point. So when he was healed, he managed to gather some funds, not through donors, but just donations within the group and himself as the leading person. Then we trained people. We were able to train people in IEC materials, of course, in conjunction with the district health office in Mpongwe. And so after that, we were able to look through DHO, through district health office, we are able to look for IEC materials. And in that material, one of the IEC is talking about how to use mosquito nets, and also the importance of mothers being under mosquito net during the time of their pregnancy, and also describing the malaria itself. What is malaria, the symptoms, and so on. So we were able to source such kind of material through district health office, and also through interaction with the Churches Health Association in Zambia, that is doing so much also in malaria. We have also been able to participate in Malaria Day and the Mosquito Day, World Malaria Day and the Mosquito Days. Apart from that, we have also been able to do drama, health talks, and postering of posters, malaria posters. And in that drama, we are able to depict a role play which talks about a problem that is in the community. And then we present it to the audience who are able to discuss the role play. Usually we ask questions like, what is malaria? Does it happen in our community? And also, if it happens, where do we go usually? And the people would participate and give us answers. And then we learn from them how they are. The trained health workers were able to help us to implement the community mobilization and sensitization with the 50 malaria change agents. And this is both in rural and urban areas. So we trained the 50 and 100 health workers in the use of IEC material. And we were talking about how they would communicate and how they would use the malaria IEC itself in the community. And at the same time, they were given, the trained people were also given the same material to distribute to their malaria patients that they were looking for, and also the community in general. And they conducted follow-up meetings with their patients during the period that they were with them. Now, we also have participated. Hello?
Thank you, Lottie. You are at time. This is a warning to just wrap up in the next minute.
Okay. we addressed. Therefore, I can also talk about the results. As you can see, we had 90% of the malaria patients saying that the IEC material had helped them a lot, most especially during the night. They could discuss with the family to look at the things that they did not understand. Those parents who have not been to, who are not able to read, they were using their children who were able to read and interpret. This material was given in 7 key local languages that are used here in Zambia. And also in terms of a door-to-door residue spray, we were also able to participate to sensitize people. The most important thing that they would benefit in a residue spray during that time. And working together with the Ministry of Health, which is the district health office, who are the experts, they were the ones spraying the houses. Our job was to ensure that they are sensitized.
Thank you very much, Lottie.
Yes.
We have we have one question, but please answer this very, very briefly, and then we'll need to move on to the plenary room. Thank you very much. The question is, what is the major difference between malaria volunteers and malaria change agents? Can you please respond very quickly? What is the main difference between malaria volunteers and malaria change agents?
What is the difference between?
Malaria volunteers and malaria change agents.
Oh, there is, I think it's just the interchanging of words. They mean the same. Malaria change agents are the same people who were malaria volunteers.
Thank you for that clarification, Lottie.